So there will be cases of a macular hole and retinal detachment. It's one presentation for the 2 hours, so either if you want to take a small break in the middle, we'll just take a break and then keep going. First case I present is the chief complaint is vision loss and distorted vision. It's a 72-year-old female with best corrected vision of 20/150 on the right eye. The anterior segment is within normal limits. There's nothing special, and when we look into the fundus, we see a macular hole. Very classic example. So, first of all, the definition of a macular hole is the discontinuity of the neuroretina at the fovea caused by anomalous posterior vitreous detachment. So here we see, the discontinuity. We see the retinal detachment has progressed here and causing visual distortion and loss of vision. Just to remind ourselves what posterior vitreous detachment is and the different stages. So we have here, we have here stage 1, 2, 3, and 4, beginning paramacularly. Then we have the parafoveal PVD at stage 2, and then at stage 3 it's completely separated at the macula, only attached at the optic disc. Down here you see the schematic. And then stage 4, complete PVD. So in this case, this is the situation where there's the most risk of having, of getting a macular hole. Epidemiology. The prevalence is about 7.8 per 100,000. There's a lot more females are affected, about 3 times more than males. And it turns out after about 2 years, about 12 to 13% have a bilateral affectation of the eye. And the median onset of the second eye is 17.5 months, according to this study by McCannell and Lewis. So first of all, at the clinical presentation, we have centrally blurred vision, that's grade 1. Then we have distortion of vision, metamorphopsia, and central scotoma in the later grades. Excuse me, I'll just go get my coffee. Austrians without coffee in the morning are not really happy, so I'm sorry. I'm sure this is the same for most of you. Okay, so second case is a gradual decline in visual acuity in the left eye over the last 2 weeks. We have a 69-year-old female, and she presented with vision of 20/25 on the right eye and 20/60 on the left eye. Her IOP was in normal range, and she had early cataract, and the other eye was within normal limits. I'll show you the OCT. So what do you see here? And what? And right, there's some traction. Do you notice anything else at in the en face picture? Anything? Excuse me? Right. Yeah. Right. Mm-hmm. Okay, so then we, so we're in a stage where we definitely still can watch and wait, and there's no intervention. So about 5 months later, it was stable. So we did, what do you think we did? We watched and waited, yes. Okay, so then she came back 2 months later, and we planned a combined phaco and pars plana vitrectomy. So that was in October. The visual acuity, you'll see, right? So she had dropped, her visual acuity had dropped to 20/60. But then before we could do the pars plana vitrectomy, we can see slowly it's detaching, but actually also resolving. So it's a regression of the hole. And then in November, basically the hole is almost completely closed, and visual acuity was also rose on its own. So this was just a case where while we were planning to operate, the patient took care of itself, which is something that the data shows too. It has happened frequently. I don't know how it is in your part of the world or in your hospitals, but sometimes we don't get OR slots that quickly, and then we feel like, oh, I would have operated the patient a lot earlier if I could, but there is a lot of good data showing it's not. If it's still in progression, you don't have to operate right away. Right. So she turned out without any intervention at 2025. So that was quite an impressive development. So if you look at the natural history of full thickness macular holes, visual acuity of under 20 of 200 is the case in the majority of the patients, 74 to 79% at 3 to 5 years without treatment. So you'd say, well, we have to treat, right? But it depends largely on the stage of the disease. Another interesting finding was that there is no significant association between the stage of the macular hole at the baseline and the visual acuity at 5 years, which kind of seems to contradict some things that I will present later. And we have spontaneous closure rates of reported between 11 and 5% in grade 2, and in later grades, smaller, around 4%. So the question is, when do I wait and when do I intervene? The International Vitreal Macular Traction Study Group came up with a classification, and that's what we were showing earlier. So we have the stage 0 is just the adhesion, vitreomacular adhesion. Stage 2, also known as impending macular hole, we have the traction. There's actually traction pulling the macula. Then we have a small hole, which is small or medium hole with traction, medium to large with traction, and then we have stage 4 with PVD, complete PVD, but that's with or without macular traction. Let's take a look at some pictures. So we have, for example, focal vitreomacular traction, or the area of adhesion is smaller than 1500 microns. And then we have these broad-based vitreomacular tractions, which really you see the adhesion basically is huge, you know, over 1500 microns. And now to look at the difference of small, medium, and large. We have here the small that are about smaller than 250 microns. We have medium ones that are between 250 and 400, and then large greater than 400. And you sometimes wonder, how do they get the numbers? I think you're going to get all the slides, as far as I know. Okay, yeah, good, sure. So we say, how do we get to the numbers? You know, is 400 just some kind of number that we like, or what would your idea be? How do you come up with numbers of dividing a classification? What would your ideas be?
By OCT.
It is by OCT, yes. But if you were to classify a new disease that you found, so you can put your name on it, no, and then you were trying to figure out why would I make a group A, B, C, 1, 2, 3? What would be the reason? Right, yeah, prognosis, treatment plan, right. It's not just to have a nice, like we all say the Germans like everything organized. No, it's not just about being, organized, it's about prognosis. So we saw that, in this I'll show you later, that when holes are larger than 400, then there's a huge drop in the visual acuity later, right? Let's talk about the treatment. So Wendell and Neil Kelly, Robert Wendell and Neil Kelly came up with the first treatment for macular holes back many decades ago, and published it in the 90s. When most of us were still kids, right? So, and the big question was, what do we do with the ILM? So, do I leave it? Do I peel it? Do I just... So there was a study, again, to compare all the studies they had done before and see, is there a profit? Is there a positive effect of peeling ILM versus non-peeling it? And if any of us knows a little bit about statistics, what do we see here? That all the studies, I mean, they're not many, but we have all the studies favoring ILM peel if we think of primary closure rates. So is the macula anatomically closed at the end of the fovea closed at the end of the surgery? And then we also have studies that looked at visual acuity after 6 months. And here we clearly also see, again, altogether, it favors ILM peeling. So the available evidence supports ILM peeling at the treatment as the treatment of choice for patients with idiopathic stage 1, 2, 3, and 4 macular holes. And by the way, if you have any questions at any time, please feel free to ask. So, maybe one of the questions is, do you use acryplasmin? I don't know, does any one of you have any, do they use it at your hospital or your university? No. Not available, okay. Right. But the important thing is we would only use it if it has a VMT. We personally don't use it. It doesn't, the risk benefit, and yeah, in our hospital I haven't seen them use it since I've been here. But it only makes sense if we still have the traction, right? As I was talking about, size matters. How do we get these classifications based on the size of the hole? So, D.H. Steele and his group looked at the factors affecting anatomical and visual outcome after macular hole surgery in the UK. And if you look at this graph, you see percentage of eyes that have failure to close, right? And here we see where the breakoff point is over 500, right? So that's why they classified the up to 400. And it actually, there is evidence, this study group suggests that you start at 500. So that's the thing, you have a little bit differences in how to classify it, because your study shows maybe 500 would be the better cutoff. So things are still moving and will still be discussed in the future. Now, some classifications are really great for scientists, but if you sit in in your daily work, you're like, how in the world should I remember all this? So this is just a slide to show that there's ideas of how to do different classifications. And they're talking more about big, especially about the large macular holes. So here we have holes, they make it really easy. It's sort of like when you go to the H&M or whatever store you have where you are, small, medium, large, X large, triple X, and then this is more, normally in the US we have the triple X, but they call it giant. So we have giant holes. I think triple X was already used for the movie, so we didn't want to use it there. So we just have a definition by the size, and then you look at the holes if there's a cuff or if it's flat. You look at edematous edges, and then you look at the VMT if it's focal or diffuse, so broad-based or diffuse, and we have if there's any epiretinal membranes. And this group was also looked at a whole group of what big holes they operated on, and showed different techniques that they could use. So there's amniotic membrane. I'll show you the studies to that. Hydrodissection, ALM flap, or even autologous retinal transplantation. This is just a typo here, because this should be a percentage. It's not 885. It's just, it was in the, even in publications they sometimes make typos, I think these are.
Yes, like I have.
Oh, you printed them out. Okay. Ah, nice. Sorry I was late. I should have handed it in early, but life is busy. Just to show you, this basically is not going to be practical probably in your practice, but it's just to show you what criteria you can use to to make a new classification. Okay, I present case number 3. So here we again have a gradual visual decline and massive metamorphopsia, distortion in the right eye lasting for the last 3 weeks. 72-year-old female again, so even in our cases we do have 3 to 1, so it's the probability of having ladies come is a lot higher. And we have 20/80 vision, non-corrected on the right eye. Patient is pseudophakic, and as you can imagine, we see a macular hole on the right side and no changes on the left side. So what would you say? I mean, you don't see the exact status of the optic disc, but what would you say from this picture? Does anybody have an idea what stage we're at? We're probably 3, yeah. Okay, so we planned a peeling, a PPV and peeling procedure. Remember, the patient is pseudophakic. In our practice, we mostly do the cataracts, even if they're very early cataracts, because they've developed cataracts often in the process, depending upon the patient's wishes too, because if they're high myopic on one eye and then they have to do the second eyes because they do the first eye and you get into that kind of problems, we sometimes will wait. But within a short period of time, a lot of patients get cataracts. So then we have, on the day of the surgery, we still did another OCT to just check if it didn't resolve on its own. I would suggest that, just because you don't want to get into an eye and be like, oh, wait a minute, everything's okay. Right, and so here we see the postoperative result. And vision went from 21/20 to 20/50. We use 0.5 and 0.6 where we live. Probably most of you, but this was prepared for the Austrian-American Foundation, so we did the Snellens, which sometimes is more like numbers for me. So, the factors influencing visual success. So vision greater than 612, 05. And again, Steele looked at, there's the post-op visual success, there's the factor of better pre-op visual acuity, smaller hole, shorter duration of symptoms, and 4 months seems to be a cutoff. So if you have a hard time getting an OR slot, then try to get it in before 4 months, which is probably doable if you have the data to show it. I mean, it depends how your system works, but we see here the preoperative size of hole and duration of symptoms. Sometimes we don't know because patients might have been noticed it after they had a cataract surgery, and then you have no idea when it started. So you have situations where you have no idea. And then another important thing is presence of AMD or lack of AMD is a positive predictor. I mean, silly question. What would you have a question?
We have a microphone.
Okay, sure. Please. No, I'd love to. No, please. I'd rather. Interaction is great. Yes, here.
And which one is better to do surgery at which stage?
Right.
And when it's more important to do, okay, when we have best result until the fourth stage, or also we have best result at fourth stage?
Right. So that's a good question, and I'll be answering that in the yes. Yeah. Oh, great. No, that's good if you have. That's perfect because the questions are coming up, and you're like, when is he going to talk about this? And that's part of what I'll present. Yeah. So generally, if you have macular holes, yeah, I'll show you. That question will be answered. Another important thing is which tamponade do I use? Do we use gas? Do we use air? Do we silicone oil? And the Bears looked at this question last year, and basically the current evidence shows that there's no evidence base yet, real clear. Okay, and so we are at a point where we can't say it's the best way to go is to go with gas or to go with oil. It's still very individual because the data, the studies have not enough studies have been done. So, as I said earlier, we can use air, we can use different kinds of gas, hexafluorine, and then silicone oil. These two different gases are, so I would say this gas stays in about 3 weeks or so, and then this one stays in longer, up to 4-6 weeks, depending on how much gas you put in. So if you're thinking about, I want to have longer duration of action of this gas, then I would put in the higher grade gas. Or silicone oil, depending also upon, sometimes we have patients that cannot, for the life of them, cannot lay on their belly and do prone position. They won't. So then you can put a heavy oil in, but you have to think of the fact that the heavy oil is a little more invasive too, and you have to take it out again. So there's different considerations. Okay, with gradual visual decline and distortion in the right eye lasting for 2 months now. 74-year-old female, and vision is 20/80 on the right eye, 20/20 left. Again, pseudophakic, and fundus examination shows a macular hole on the right side. We also have the problem in the past medical history, lower back issues, and so we come to the fact that this patient will have trouble with positioning. What do you notice on the edges here? Cysts, right? We have edematous edges. The edges are sort of rolled up. And so we still decided to do PPV and gas. And this was about a month after post-operative. What do you see? Not really a lot of change, right? No anatomical closure. We see actually more of the edema, and you can see here that there might be some epiretinal membrane, so we have some issues to take care of. And it's shrinking, right? Yeah. That's stage 4, yes. Well, it could be, that's the problem here. We don't see, so the pictures, I always have to take pictures that have been so if I know I'm going to have a lecture, then I would probably do a bigger, you can do a larger cutout and then have it go all the way over to the disc, and then you'd see that the Weissring or so, right? Okay, so stage 3 or 4. And one thing we have to say is she had lower back pain. Sometimes they don't say it beforehand. They'll say, yes, I can do this, and they can't. So it's very important for us to have that talk to see how the positioning is possible. And then we have a culprit. We don't say, oh, the surgeon did a bad job, so we say the positioning was wrong. No, but don't tell anybody. No, I'm joking. No, so we have. It's unsuccessful. So let's look at the question if it was really the positioning. So Tadeoni looked at a study about the positioning, and it was a prospective randomized 69 eyes. Not a huge study, but still it's at least prospective and randomized. Here 150 eyes done by Guillaume B. And comparing face down and a seated position after macular hole. And what would you think, what would you expect the results to be? Let's see. So, macular holes smaller than 400 are not significantly influenced by postoperative face down positioning, which is now interesting because we always had a culprit. We said, oh, they couldn't lay on their face, they couldn't lay on their belly in the night, and the gas didn't push up, and so that's one reason why. But if you don't, you have to think of, bless you, sorry. So if you think of the fact if the eye is very full of the gas and you are sitting in prone position, it's still pushing back as long as you have enough gas in the eye. And you're giving the people a lot of easier time for the first 5 days. Right, so here we have the graph, and we see it favors so this is face down posture and non-face down. So in this study, it favors for large, and now remember this is important, so you have to, size matters, large and small. So large idiopathic macular hole surgery, it's important to do your face down. Because so if you look at the odds ratios, if you look in this study now, okay, so all together, if you take everything together, it's around 4. So the chances are 4 times better if you use that than if you don't. That's the numbers. Meta-analysis is great because you have all these different studies, but then you also have to be careful which studies do you choose, which studies do you kick out, which studies were done in a way that I can use the data, so there's different problems with that. Okay, so if you look at here, the subgroup analysis of the large holes. Important was also that they use less than 3 days or more than 5 days, and you see here the p-value is significant. And then the follow-up period is also a huge thing, because if you just look at them for 3 months, then you get a good answer, but you don't really know yet if it's going to stay that way. Okay. So again, face down positioning after large macular hole surgery over 400 maybe have beneficial effects on anatomical outcomes, and the recommended duration of positioning is at least 5 days. Now, I don't know how is the situation do you have like a ward where you stay, where you have the patients stay, or do you have like a hotel situation where they come and, you just visit, you do they go home? Okay. First day? Okay. Okay. Yeah, we still have this old mentality here. We have a ward, we can keep them for as long as we want to. And so we keep them because we have this sort of like, when you go to the massage guy, you have like this face thing and you can put your face on it. And I mean, sure, you could also give the patient that, but they probably won't give it back. Take it for home. No, but anyway, people just tend to do less, be quiet, or not start doing housework or whatever when they're at the hospital. So we have the possibility of having them at the ward. But I know in the U.S., for example, there's no way. I mean, you never pay for that, to have somebody stay at the hospital for 5 days. I mean, they send you home after, major surgery the next day. So that's we're just in a different world here. So, excuse me? Oh, right. Okay. That's funny. She said that, I don't know if everybody heard it, but they have separate wards for cataracts and retina surgery, or else the cataract patients would all go lay face down because they want to be very good patients, probably, and do everything right. Okay. Well, another reason is that... Go. Right. That's right. So, and sometimes I also have it's mostly older patients, and then we have the family, and so sometimes we try to really figure out, is this, or for example, if they have a similar situation as subretinal hemorrhage, and if we do RTPA and gas. And then the people are like, well, does it even make sense to put gas in if they can't position their face, right? So, yeah. Okay, this is number 4. We have a patient who has had surgery and doesn't want any gas anymore. So she already had the gas, right? This was the patient from earlier. And we decided to go in again with silicone oil. And, as you guys all saw, peel the ILM another time, because we see the ILM and the membranes. And we have an encouraging outcome for what she started out as, definitely. And also, very important, something that patients often complain of is the distortion, more even than the visual acuity. So people will sometimes be happy to have 20/80, 20/100, whatever, but they're very unhappy when they have distortion, especially because the second eye seems to mess up their vision on the second eye and interfere. What to do if the hole didn't close? What? Mm-hmm.
I like ILM flat, but they already took the ILM.
Right. Yeah. So we can't go back there. But now here it did close. But if you could do that, you could do an ILM flap instead of oil. She didn't want any gas. She said, "I don't want to lay on my face. I don't want to." So. Right. So we have different options here. We have the ILM flap. You invert the ILM flap. Then we have amniotic membrane plug. What do you notice in this picture here compared to here? It's quite a bit of scarring. So sometimes I wonder, you have, yes, it looks a lot better, It's happy. We're all happy, we can sleep at night because we did a great job. But the question is, I sometimes wonder, what is the patient? Is it going to be a big difference for the patient? But there are patients that will and you have to kind of filter them out, is they will not be happy until this is turned into this, no matter what this looks like and what it means for them. So I mean, that's part of our deals. Happy patient, happy doctor on the one side, but on the other side, we're supposed to be evidence-based, and we have to have some kind of a goal to reach, right? So it's a sort of a discrepancy sometimes. But I mean, I'm not in private medicine, so it's not like I have the, this is a patient that pays so much and whatever, so it's a little different. And then we also have the platelet concentrate. Right, so, and some people put this right there. I personally don't have any experience with that, so I have my teacher is, and I'm still in the process of working on this. He's more concerned. He's not so into these kind of techniques. So maybe it's a generational thing. I don't know. I hope he doesn't listen to this. Case 5. So we have sudden visual decline in the right eye 3 days after playing outside, and it's a 12-year-old male. So now we're not in a idiopathic macular hole. We have a kid playing outside. Now there's no clear story of what exactly happened outside, and that's one of the problems with 12-year-old kids. You'll often not get the real story. Was it a ball? Was it a stick? You could see if a stick was hit in the eye, but we don't have the exact story. We see the anterior segment is slightly affected. It was probably some blunt object or a fist, Boys and what they do. If they only play computer games, then they get myopia. So you have to choose between myopia and some different trauma. So this was the presentation. What do you see on the en face? What do we have here? Yeah. It's pretty broad, pretty big area. And here we have a beginning retinal fluid. That's the optos. We have here a little hemorrhage. We have a Berlin's edema. And visual acuity is actually declining, right? So on presentation, it was 2060. No, wait a minute. No. Wait. Excuse me. Go back. Oh, right. It was 2060. Yeah, and so that was slowly getting a little better. Not much. You can't really say if it's much difference on the next day, right? And then we waited for 3 days. What do you think happened? It's resolved, okay. Who thinks it doesn't resolve? It doesn't? Well, now we're talking about 3 days later. We're not talking about long term. Okay, so 3 days later, because that's the thing, you're sitting there, you're like, well now, oh no, it got worse, or it got better, or what do I do? It got better, okay. Okay, well, we have a decline again, but again, 2080. And here you see, it's hard on this projector, but you see the whole, and if that was the beginning, we see there's a, ooh, yep. What do we do? What do you do? Wait, watch. Weight watch. That's something else. Weight watchers. Okay, so then we wait another week, and it's like, oh, what are we going to do? He's 12 years old, so what are you going to tell the parents? We're going to wait. Oh, disaster. And you still have acuity. So we schedule an intervention, right? But then, if you look at the difference between here and here, what do we notice? It's kind of approaching again, right? And then it's starting to resolve, and we see here very clearly there's a positive trend or a big. So at the end, oops, he ended up not being. We waited, but in the meantime, we were already ready to operate. So it's like sometimes you need to really have good nerves or know what you're doing. I guess that's better. So secondary FTMH, we have the differential diagnosis blunt trauma. That's what we had in this case. Lightning strike, which is crazy, but yes, we have bilateral macular holes after getting hit by lightning. It's not too uncommon. What else can you get in the eye? Cataracts, yeah. And they have really cool, there's like a flower pattern in a lot of cases. High myopia. It's a word I hate, just read it. And telangiectasia or so, yeah, and macular sciasis and wet AMD. And in this case, it was blunt trauma. So back to the decision-making process. There is a good basis on which to wait because spontaneous closure rates are 40% in all patients, and in children, even up to 50%. So if you take the 28% of adults plus the 50%, you come out at about 40%. But if you think of kids, if you tell the parents, okay, we have to do general anesthesia, do probably cataract surgery in a 12-year-old, or maybe we'll try it and see, but they might get a cataract later. You have all these different things, but we have a 50% chance it's going to resolve. And even if it doesn't resolve, we still can operate. Then it's a whole different, basis to make a decision on, right? And the median time is 5 weeks. And as I said, we still have the option to treat. So it's a good point to think about observing for the next 3 months. Because did you remember back when we went at the beginning, we talked about how long what is the time frame at which we have lower visual acuity at the end? It's 4 months. So you still have the data on your side of saying we waited 3 months, but then have a slot ready for OR for a surgery. They didn't have any, right, because, right, I think that's right. And also the traumatic ones are often smaller, yeah. So PBV is an established therapy option. Various options regarding technique, gas tamponade, and positioning. So we don't have a 100% clear picture that this is the best way to do it, this is the way you have to do it. And we have high morphological success rates, but usually the improvement of visual acuity, but no return to normality. So you have to prepare the patients that it's not going to be this surgery and then everything will be back to normal. There's going to be some disturbances in, metamorphopsia can stay, and visual acuity won't go back to normal. In stage 2 to 4 macular holes, and that was some of the answer that you were asking earlier. There's a clear, so there's a sort of a best treatment guidelines from the AAO. Says in stage 2 to 4, poor prognosis without treatment, you should really tell the patients that there is a good prognosis if for successful closure. And I think it's important to discuss, the benefits with the patients of doing the macular surgery, of the macular hole surgery.